Hello and good evening, everyone. Welcome to yet another session of the Grey Medicos. I am Achal Burma, the host for the event today. The pandemic has been really tough for all of us. We have missed out on our regular clinical postings and have been compelled to stay at home. Despite the odds, we have decided to utilize the virtual platform in the best possible manner, and we conduct an interactive teacher-student session every week to help novice medical students to strengthen their clinical knowledge and learn the art of history taking to reach a diagnosis. This platform, created by the medical students from different medical colleges of Nepal, has been named the Grey Medicos. As grey is the color that lies somewhere between black and white, and as medical students, we believe that we are in the transition from knowing nothing to knowing something. We have chosen the name the Grey Medicos considering this analogy. Today, we are going to have a discussion on ruptured ectopic pregnancy. We have Dr. Shantosh Sharma as our mentor. Dr. Shantosh has completed his MBBS and MD from Institute of Medicine, Tribhuvan University. He is currently working as a lecturer in the Department of Obstetrics and Gynecology in Kist Medical College. We are grateful for your presence and we extend a warm welcome to you, sir. We also welcome our presenter, Dr. Samyam Bickram Pathak, who is currently working as an intern in Kist Medical College. I now hand over the floor to Dr. Samyam and request him to start his presentation.
Thank you so much, Achal. It's a great honor to be here to present on a topic of ruptured ectopic pregnancy in front of you all. So I'm going to share slides for the day. So am I audible? Can I start?
Yes, sir, you are audible.
So once again, good afternoon, everyone. So let's begin our topic for the day, ruptured ectopic pregnancy. So let me start with the presentation, ectopic pregnancy. So as we all know that ectopic pregnancy, it's an implantation of fertilized ovum outside the normal uterine cavity. However, it's not always synchronous with the extrauterine pregnancy. According to various data of different countries, in India, it is around 1 in 150 by 150 to 300 cases, whereas in UK, it's 11 by 1,000 mature intrauterine pregnancy all occur with the ectopic pregnancy. These are the references which I have kept in the slides from where it's taken. Similarly, in our context, approximately 1 to 2% of all naturally conceived pregnancies end up with the ectopic pregnancy, and which is usually vulnerable. And as we all know that the most common sites of ectopic pregnancy is the tubal pregnancy. That is, we must remember the different parts of fallopian tube, and most commonly the 95% among the tubal, it's common in the 55% in the ampullary portion, 25% in the isthmic portion, 18% in the fimbrial, and 2% in the interstitial. Similarly, followed by, we have ovarian, abdominal, and cervical, and they have different criteria to diagnose it as an ectopic pregnancy in the respective site. Major complications of ectopic pregnancy occur generally in the first trimester pregnancy, resulting in increased mortality and morbidity. This was a short introduction regarding ectopic pregnancy. Now we will have a brief case scenario which presented at our hospital, admitted on Baisakh 6 and discharged on Baisakh 10. So moving forward. So our case is a 21-year female S. Lama from Imadol, Buddhist by religion, married, homemaker, who presented to our emergency department with a chief complaint of cessation of menstruation for 2 months, lower abdominal pain for 3 days, followed by pervaginal bleeding for 3 days. Patient's last menstrual period was uh, 2000 burning micturition or increased frequency of micturition. When she was asked regarding her menstrual history, her menarche was 14 years, duration of flow was 3 to 4 days, with the length of cycle was 28 plus minus 2 days, and it was regular. She used 3 to 4 pads per day, partially soaked, No history of clots, dysmenorrhea, intermenstrual bleeding, or postcoital bleeding. She was a gravida of 2, parity of 1, abortion 0, and a living issue of 1. Married for 8 years, she had a 6-year-old male baby with a normal delivery born at a health post. The couple had not used any method of contraception till date. There was no any significant history of hypertension, diabetes, thyroid, tuberculosis, blood transfusion, or surgeries in the past. And also there was no any relevant family history. Moving towards her personal history, she was non-vegetarian by diet, does not consume alcohol, and non-smoker. No significant drug and allergic history, followed by long-term treatment history in the past. This was a brief history that was taken. And moving towards her examination during the time of her presentation at emergency, she looked quite ill-looking with an IV cannula on dorsum of her right hand. Her vitals were: pulse was 110 beats per minute, regular, normal character and volume with no collapsible pulse and no radial delays. Blood pressure was low, that was 90 by 60 millimeter of mercury measured in left arm in supine position. Temperature was 98.2 degree Fahrenheit in left axilla on supine position. Respiratory rate was 45 breaths per minute, which was high, and it was of thoraco-abdominal type, with the oxygen saturation of 95% in room air. Moving towards her cardinals, pallor was present while examining the face and the hands, while there was no any icterus, edema, cyanosis, lymphadenopathy, clubbing, or features of dehydration. Similarly, on systemic examination, chest examination there was bilateral vesicular breath sounds heard with no added sounds, and on cardiovascular examination, while on auscultation, first and second heart sounds were heard with no any murmurs. As we all know that per abdominal examination is very important in all the obstetrics and gynecology cases. So here is the examination findings of the respective case. On inspection, abdomen was flat, soft, umbilicus was centrally placed, inverted. All quadrants moved equally with respiration, with the flanks not full, no scar marks, no venous prominences, and hernial orifices were also intact. On palpation, tenderness was present over the right iliac fossa and suprapubic region, and temperature was slightly raised on superficial palpation. However, there was no organomegaly in case of deep palpation. Percussion, there was no any signs of any distension, and on auscultation, normal bowel sounds were heard, that was around 3 per minute. So, per vaginal examination was generally not done as per patient's comfort in emergency. However, it is also not recommended in acute presentation due to risk of more bleeding and pain. So if done, generally the mass in adnexa can be felt along with the cervical motion tenderness. So after this complete history and examination of Ms. S. Rama, various investigations was sent, which are as follows. So hemoglobin was in the low range, that was 7.9 gram per DL with a packed cell volume of 28%. WBC showed a TLC of 11,200 with a differential count of 67% neutrophil, 1% monocyte, 4% eosinophil, and a 28% of lymphocyte. RBC was 3.14. The platelet was 284,000 per cubic millimeter. She had a B positive blood group. Her RBS was 95 mg per DL, PT was 14 second, and an INR of 1. Serum regarding RFT, serum urea was 24, creatinine was 0.6, sodium was 141, and potassium was 4 millimole per liter, respectively. Routine microscopic examination was within the normal limits. So a clue to the diagnosis reached when we had a USG abdomen and pelvis, where it shows a mixed echoic lesions in right adnexa with minimal fluid in peritoneal and pelvic cavity. Findings were highly suspicious of ruptured ectopic pregnancy and a differential diagnosis of ruptured ovarian cyst or left renal completion. So this is not the exact USG of the patient, but however, it somewhat looked like this in case of ultrasonography, that is the ectopic gestational sac is generally seen. And the patient was then immediately shifted to operation theater for emergency laparotomy procedure. The operative management that was performed to the patient was emergency laparotomy with right-sided salpingectomy done for the right-sided ruptured tubal ectopic pregnancy. at G2, P1, A0, L1 at 8 weeks of gestation. Her OT findings during the time of operation were hemoperitoneum present, that was 250 ml of blood plus 70 ml clots were present. Right-sided tubal ampullary rupture, right ovary and tubes were normal, and left ovaries were not visualized due to the adhesion to posterior wall. So it was history, examination, investigation, and finally the operative procedure was done. Today, this topic was brought into discussion because ectopic pregnancy is always a ruptured ectopic pregnancy is always a life-threatening condition, and it leads to bleeding. The patient may present with the features of shock like tachycardia, hypotension, tachypnea, decreased urine output, and urgent resuscitation is immediately required, and a blood transfusion is required in such case. The patient lands up in the emergency, and it is often misdiagnosed with various differentials like PID, a ruptured corpus luteum, and the treatment is mostly delayed, which may be the cause of maternal mortality. And our goal is always to reduce the mortality cases in the country. So this topic was brought into discussion today, and the causes cannot also be ruled out in 50% of cases. We have read almost 8, 9, 10 causes of ectopic pregnancy, but however, in most of the cases, causes cannot be ruled out, even in this case too. So this is a figure. It's not a case-related figure. It has been extracted from somewhere else. And it is just to show you a hemoperitoneum, that is a ruptured ectopic pregnancy and a clotted blood. And to relate it with clinicals, which is rarely done nowadays, and it is a cultosynthesis. That cultosynthesis is a procedure in which aspiration of fluid from the pouch of Douglas or rectouterine pouch is done. And presence of non-clotted blood in the pouch of Douglas is indicative of hemoperitoneum, which is rarely done nowadays. So this is the figure of hemoperitoneum with the clotted blood. So talking about the overall course during her hospital stay, patient was presented to emergency. All the relevant investigations were sent. Emergency laparotomy was planned, blood was arranged, resuscitation was done side by side, and the patient was shifted to operation theater. Post-operative diagnosis of right-sided tubal ampullary ruptured ectopic pregnancy was made. Patient was managed post-operatively with IV fluids, antibiotics, and analgesics. Post-operative event was quite uneventful, and after 48 hours, she was managed with tab ciprofloxacin, tab metronidazole, tab ketorolac, and a tab panta. Injection Incifer, that is your iron sucrose, 2 ampules was also given. After the contraception counseling, Jadel was inserted and patient was finally discharged on the 4th post-operative day. Patient was hemodynamically stable at the time of discharge and called for regular OPT for further consultations. So this was a short case of a ruptured ectopic pregnancy in which the life of a patient was saved on timely diagnosis and timely operative treatment. So ectopic pregnancy, it should not always be suspected in all women of reproductive age who present to your ER with your abdominal pain and features of pallor or shock. Index of suspicion should be high in the following group of patients if there is history in the following, which have been listed in the slides. That is the history of infertility for your long periods, previous tubal surgery, history of pelvic inflammatory diseases repeatedly, history of tube ligation, if there is a past history of ectopic, subsequent ectopic and occurring 10 to 25%. Pregnancy in IUCD users and failure of IUCD can lead to immobility of ovum, and ectopic pregnancy can result ovulation, induction, or in vitro fertilization. These are some of the points that can be mentioned in their history. Similarly, the classical triad that we all have studied in our classes, that is the amenorrhea, abdominal pain, and abnormal bleeding, generally occur in 50% of the cases. However, there might be no symptoms at all. That's why also we need to both diagnose ectopic on time, and it might be cumbersome. So it varies greatly among individuals and are confused with other conditions such as PID, spontaneous abortion, and ovarian cyst. So treatment options for the ectopic generally include surgical, that is laparotomy or laparoscopic, medical treatment, and a brief surgically assisted medical treatment. So I'll be also briefly discuss about the treatment options in brief. So let us move. So according to the National Journal of Obstetrics and Gynecology, among 300 consecutive women with surgical and histological diagnosis of ectopic pregnancy, they found that 77 had pelvic inflammatory disease, which is the highest number, followed by 46 had a history of abdominal pelvic surgery, 32 had both PID and a history of abdominal pelvic surgery, 43 had used an IUCDs, and 32 had a device in utero at the time of ectopic pregnancy. It is always essential to identify the signs in acute presentation, and resuscitation is carried out while preparing for definitive management. IV fluid infusion, hemoglobin, blood grouping, cross-matching must be done immediately, and prepare the patient for urgent laparotomy is must. So as we did radical surgery or salpingectomy, so what are the points to be considered radical surgery or salpingectomy? So the following points are to be mentioned. They are the ruptured ectopic, which was in our case, uncontrolled bleeding, which was also matched in our case, and extensive tubal damage. Followed by, if there is large tubal pregnancy, that is greater than 5 centimeters of sac, recurrent ectopic on the same side, and previous reconstructive surgery of the tube. These are the main 6 points that you must remember, which are also the indications of a radical surgery. Besides this, there has been also mentioned about the laparoscopic surgery in case of ectopic pregnancy, and what points are to be considered in these are: if your ectopic mass should be less than 6 centimeters in diameter, serum beta HCG less than 600 microunits per ml, it should be a tubal pregnancy, and there must be minimal adhesions of the tubes. So these are the criteria for laparoscopic surgery. I talked about your radical surgery, laparoscopic surgery. Similarly, there are also some conservative surgery, which is generally done for unruptured ectopic for future fertility when your contralateral tubes are also abnormal. So some of the conservative surgeries are salpingostomy, which is your opening the tube and removal of ectopic; salpingotomy, which is opening, removal, and further closure of the tube. Thirdly, we have the milking in the fimbrial and ampullary pregnancy, ectopic pregnancy. And on fourth, we have segmental resection and reanastomosis in ischemic. We all must also know what are the medical management for ectopic unruptured, not a ruptured, but an unruptured ectopic pregnancy. So some of the eligibility criteria are: if the patient is hemodynamically stable, if the patient is reliable and compliant and can return for follow-up for various investigations, if the ectopic pregnancy size is less than 4 centimeters, there is no any contraindication for methotrexate, and since methotrexate is a drug of choice in unruptured ectopic pregnancy, there must be normal blood count, kidney function, that is your RFT, and the LFT should also be normal. No suspected heterotopic pregnancy, and if the patient has desire for the future fertility. So how is an unruptured ectopic pregnancy managed? Ruptured, we all have already seen a case presentation. For unruptured, there are a single dose and multi-dose regimen. However, single dose is mostly preferred. So it is around methotrexate 50 mg per meter square intravenously or intramuscularly. Beta HCG is measured on day 0, 4, 7. There should always a fall of 15% between day 4 and day 7. So on multi-dose, we have methotrexate and leucovorin. Methotrexate 1 mg per kg IV or IM, followed by leucovorin 0.1 mg per kg orally 24 hours later after methotrexate, and the dose repeated every alternate day up to maximum of 4 doses until your beta HCG declines by 15%. And it is very, very essential to measure the SS serum beta HCG at day 0, 3, 5, 7 until it declines by 15%. After result is achieved, patients is monitored with weekly beta HCG and seen whether it is detectable or not. So this was a short introduction, short case presentation, and a short discussion about your ruptured ectopic pregnancy. So even though now the conclusion is that it is very, very essential to diagnose ectopic pregnancy, as the severe morbidity and mortality of our mothers can be prevented on time. Management should never be delayed and immediate intervention should be taken. It is always a group work to save the life of mothers And yes, ectopic pregnancy complications can definitively be treated. Preventing ectopic pregnancy can definitely contribute towards reducing maternal mortality deaths in the future. So thank you everyone for your attention.
Thank you so much, Dr. Samyam. Now, I would like to request Dr. Santosh to kindly give certain inputs on the presentation and
Good afternoon, everyone, and thank you very much for providing me this opportunity to share uh, something regarding the ectopic pregnancy. And I would like to, okay, so congratulate Dr. Samyam for giving very nice presentation. It is very concise, comprehensive, well-structured, okay, fulfilling all the norms, most of the norms of PowerPoint presentation as well. It's well structured, so I think almost it's very clear. So there are a few things, okay, to bear in mind. um, so as he has already explained, so you should remember that ectopic pregnancy is it's atypical pregnancy. So so there are basically three types, okay? So ectopic, eutopic, and heterotopic. So ectopic means it's when implanted outside the lining of the uterus. So it doesn't mean that just mere presence of the fertilized ovum, okay? So because fertilization takes place in the ampulla, okay? So he has started with the introduction with the definition, and then it follows the it was followed by the incidence. So it is quite common, 1 to 2%. So so once you are active in clinical posting, then you will encounter, okay, one day surely you will encounter this case, okay? So that's why it's very, very important, and very nice topic was chosen for today's presentation. So okay, so regarding the case, there are few things I want to clarify, okay? So it was well presented, and you should know the art of history taking. And in this case, uh, luckily this case has a triad of pen abdomen, PV bleeding, amenorrhea, but you don't need to look for the triad in all cases. It's just in 10 to 15% of the cases you'll get such a triad. But once the patient with a pregnant patient or early, sometimes the patient may not be aware of pregnancy. That's why we need to confirm it in emergency, okay? But remember, if the patient with a pregnant patient with pain abdomen, you should always rule out ectopic pregnancy, okay? And this patient, luckily this has all pain abdomen, PV bleeding, and amenorrhea. That's why she was diagnosed she was diagnosed quite quickly. That's why you couldn't get all the signs, okay, which you can see. Like if the patient presented quite late, then the patient may be in a frank shock, okay? So and there may be huge hemoperitoneume, but in this case there was just around 250 300 ml of hemoperitoneume. That's why there may not so you may not appreciate all the signs, okay? So regarding history, it was well taken, okay, and it was summarized very well, very concise. And you should must bear in mind that so during the history taking, uh, those are the relevant point, okay? So almost all points has been covered regarding like the history of presenting illness. He has elaborated quite well, okay? So here the nature of the pain is different than um, other type of pain during pregnancy, okay? Sometimes just urinary tract infection, constipation may cause pain abdomen, but here usually the pain is quite atypical type, acute onset, okay, and sudden, and the patient may give the history of other atypical pain like referred pain to the shoulder okay? So the nature of pain, so while taking history you should bear in mind the nature of pain, okay? So you should know how to elaborate the pain. um, PV bleeding, yes, there is a slight bleeding. There is not heavy bleeding in ectopic pregnancy, because especially when it is ruptured, the bleeding is because of withdrawal. Okay, it's a withdrawal bleeding. Since the beta FCG, okay, it usually maintains the pregnancy. So when there is withdrawal, Okay, when there is a rupture, okay, there is loss of all those synthesizing cells, okay, which secrete beta acids, that is interior trophoblast. Okay, and because of that there will be withdrawal bleeding. That's why it is not that heavy bleeding. Okay, so there is a slight bleeding, and because of the rupture and leading to the collection in the peritoneum and um, it inside the pain. Okay, but sometimes, okay, sometimes it may not be ruptured, so those cases are usually diagnosed by ultrasound. Okay, so clinically it's very difficult to diagnose the unruptured pregnancy, but if the patient land up in emergency with a pain abdomen, you always have to suspect ectopic. Okay, and in this case, okay, regarding the past, although history was very relevant, and regarding the past history, what I would like to say is, okay, so especially you should focus on if there is any tubal surgeries. Okay, if there is any history of pelvic inflammatory disease, okay, any history of recurrent PV discharge, lower abdominal pain, okay, deep dyspareunia, if all those things come in history, then you should focus in the past history. Okay, but at the same time, as Dr. Samyam has okay recurrently stressed the same point. Okay, so in almost 50-60% of the cases you may not find any risk factor, okay, or any relevant past history. Okay, so same in this case. So in this index case we didn't get any relevant past history, but you should inquire, okay, if there is any history of tubal surgeries, any history of recurrent uh, feature suggestive of pelvic inflammatory disease like lower abdominal pain, PV discharge, okay, a deep dyspareunia, okay, any history of past ectopic. Okay, this is very relevant. If the patient has a past history of previous history of ectopic pregnancy, and you should always counsel the patient that in subsequent pregnancies she may have similar condition, okay, ectopic pregnancy, because most of the cases we encounter, okay, those with a known risk factor, it's because of pelvic inflammatory disease. Okay, and pelvic inflammatory disease is a bilateral disease. Okay, it affects both tubes, not only one. Okay, that's why if the patient has pelvic inflammatory disease and it is because of pelvic inflammatory disease, PID, the patient had ectopic, okay, in the past, then you should always counsel the patient in subsequent pregnancy. Almost around 15 to 20% of the cases they may have a recurrent ectopic, because the tubal disease is bilateral in case of pelvic inflammatory disease, or sometimes patient may have congenitally long, okay, tube. Okay, so that's why, so recurrence is also very important. Okay, so it's almost 15 to 20% of the cases, so that is very important point. So in past history you should always ask if there is any past history of ectopic pregnancy. It doesn't matter if it was managed medically or surgically, but the past history of ectopic pregnancy is very important. Okay, and apart from that, like pelvic inflammatory disease, any tubal surgeries, okay, so these are very important. Okay, and other comorbidities which was well explained, okay, like hypertension, diabetes, because most of the cases they need surgery, and for surgical fitness you need to ask those questions as well. Okay, and usually ectopic pregnancy is an acquired condition. Okay, that's why it doesn't run in family. Okay, but sometimes there may be certain condition, okay, like congenitally long tube, there may have some association, but there is family history is not such relevant in ectopic pregnancy. Okay, as past history is very important. Okay, family history is not that relevant. Okay, sorry, I missed the contraceptive history. In contraceptive history you should bear in mind that uh, if there is patient has used intrauterine contraceptive device, especially, okay, medicated copper-T. Okay, so previously they use like progestasert, okay, that is the medicated copper-T, and that medicated copper-T, because of the progesterone, okay, the tubal motility will be affected. Okay, so in that case there is usually the incidence of ectopic pregnancy is high. Okay, if normally all the contraceptive device, okay, so their main aim is to prevent contraception. Okay, so that's why it doesn't mean that it will obviously increase ectopic pregnancy, but if the patient conceived with the intrauterine device in situ, okay, then you must always rule out ectopic pregnancy. Okay, because especially the medicated copper T, which previously we used to do, we used, but nowadays Prostacyclin is not used no more. Okay, but Mirena is commonly used. Okay, so especially medicated copper T. Okay, so especially the medicated copper T, it is there is the odds is more than the non-medicated copper T. Okay, leading to ectopic pregnancy. So another one is progesterone only pills. Okay, so any hormonal pills. Okay, so they're the hormone they have. Okay, their influence in the tubal motility. Okay, the circular muscles in the tube, it affects. Okay, that's why the patient with especially progesterone only pills, okay, or uh, progesterone medicated copper T. Okay, so especially these two contraceptive device, there is a small association with increased chance of ectopic pregnancy. But remember, it doesn't mean that contraceptive method increases ectopic. If there is, if the patient conceived using such method of contraception, you must always rule out ectopic because the odds are high with those. Okay, and okay, so I think these are the important pertinent point in the history. So on examination, okay, thank you for sending the slide. In personal history, you must focus on the smoking, and especially the smoking. Okay, because smoking, it will damage the cilia. Okay, so that's why, is the patient smoker or not? This is very, very important, and you should always inquire in the history. Okay, so history part, so I think that's all about history. And drug and allergy, it's very, very important. You always have to ask, because in such an emergency setup, if we miss drug and allergy, patient may land up in another problem. Okay, there may be anaphylaxis. That's why, as a as for the patient safety, you should always ask drug and allergy. Okay, so that's about history. On examination, usually if the patient present, okay, in emergency, most of the time the patient is usually in a shock. Okay, the patient usually pale looking. Okay, looks ill, pale. Okay, so, and vitally patient shows the signs of shock. Okay, so tachycardia, hypotension, and so in this case, so you can see the patient is tachycardic and blood pressure is 90/60. So this is, it's a common presentation. Okay, so patient usually present with a shock. Okay, um, so vitals is very, very important. You have to assess the vitals, as we all assess the patient. If all patient vitals, okay, especially when the patient land up in emergency. So this is commonly we do, but remember, the most of the cases they present with shock. That's why here the examination and resuscitation should be side by side. Okay, uh, we cannot wait because there is ongoing bleeding. Okay, so that's why we examine. Once we sense that it is likely ectopic pregnancy, then the vein should be open. Okay, the fluid should be given, blood should be arranged, and the patient should be prepared for urgent laparotomy. Okay, so side by side, so resuscitation as well as examination and the preparation for theater, okay, should be done side by side. Okay, and okay, so investigation, so you can see there have been investigation, but among all, the very important is hemoglobin. You can see there's a drop in, quite significant drop in hemoglobin. It's likely, it's normal is around 12 to 14. Okay, so here you can see it's just 7.9. So there is significant fall in hemoglobin. It is because of ruptured. Okay, so clinically we can assess pallor, and it is supported by the relevant investigation. Okay, so I would like to add some few in examination. Okay, before discussing about the investigation. In examination, in par abdomen, so Dr. Samyam, could you show me that slide? Okay, par abdomen. Okay, yes. So so abdomen here, because of the patient was got very early, okay, in the diagnosis, that's why there are no obvious signs. But if the patient came with, okay, massive hemoperitoneum, then abdomen will be usually fully distended. Okay, abdomen will be distended, and remember, the flanks will be full. Okay, so all the blood collected, okay, they get occupied in the gutters, and because of that, the flank will be full. Okay, so abdomen will be distended, flank will be full. On palpation, there will be tenderness. Okay, here you can see, here the positive thing is tenderness. Okay, so that is common finding in ectopic pregnancy, ruptured ectopic pregnancy. Okay, and okay, in percussion. Okay, so if there is, so here because of the fluid, it was very minimal, around 250, around 300 ml of hemoperium. That's why it's very difficult to elicit in percussion. But you will, if there is almost more than 500 mils of hemoperium, then you may appreciate, okay, shifting dullness. Okay, so usually abdomen will be dull. So general note is tympanic, but in case of ectopic, you may appreciate, yes, dull. Okay, so if there is massive, like more than 1 liter of hemoperium, then you can elicit um, sorry, I'm really sorry. I'm sort of the word. So it's okay. I will, if I remember, I will say you. Okay, so shifting dullness and another. So could you anyone help me? um, it's a it's type of elicit. If there is fluid in the hemoperium, sorry, if there is any fluid collection in the abdomen, so there are different techniques we can elicit. One is shifting dullness, another is
The flu thrill.
yes. Thank you so much. I'm sort of word. Okay, it's a fluid thrill. So if it's more than 1 liter, then you can elicit fluid thrill. Okay, so you should look all those signs. Okay, so for this case, because we caught it early, so we couldn't elicit. Okay, and auscultation. Yes. So in massive hemoperitonum, we may, and if it is associated with peritonitis, okay, associated infection, then sometimes we may not appreciate the bowel sound. But if there is no signs of peritonitis, just hemoperitonum, then there is no, usually there is no change in bowel sound. Okay, okay. So Dr. Samyam, could you change the slide to pelvic examination? Okay, so if the diagnosis is like frank ectopic, okay, so because nowadays, because of the diagnostic modality, we have ultrasound, and because of the ultrasound, it is very easy for us to make diagnosis. In that case, if it's a frank ectopic, you may not need to do pelvic examination. Okay, because it just causes discomfort to the patient. Okay, and sometimes if it is not ruptured, okay, so during the manipulation sometimes we may rupture. Okay, but where there is a setup, okay, where there is no immediate ultrasound is available, then you have to do pelvic examination. Okay, gentle pelvic examination is done. Okay, so most of the time you will elicit cervical motion tenderness. Okay, so while you move the cervix, it will move the adnexa, and because of the stress pain, okay, in the peritoneum, it will stress the peritoneum and it elicit the pain. Okay, that is cervical motion tenderness or cervical excitation. Okay, these are the same terminology. And sometimes you may appreciate a fullness or adnexal mass as well. Okay, but most of the time the patient is usually in pain. So because of the pain, so we may not extract a good finding. Okay, but most of the cases with ruptured ectopic, you will find cervical motion tenderness. Okay, so this is all about history and examination. Okay, so let's go some questions. Okay, so okay, so very nice question. Okay, so there is one question: what are the indication to do whether surgery is done radical, that is total self-injectomy, or salpingotomy? Okay, so this is very very good question. um, uh, okay, so when to do radical surgery or total self-injectomy? When the tube is damaged, okay, when we cannot salvage the tube. Okay, so during the laparotomy, when the tube is visualized, and when we cannot salvage the tube, it's damaged. Okay, it's all ruptured and we cannot repair. Okay, in most of the cases, okay, we do self-injectomy. Okay, and we should always look the contralateral tube. Okay, so if the contralateral tube, another tube, okay, if there is ectopic, so for this case, if the tube, the damaged tube is right, if the left is normal, okay, then we always go for salpingectomy. Okay, because even one tube is okay for continuing the fertility. Okay, so for the future fertility, just single tube is okay if it's healthy. Okay, but if the tube is grossly, it doesn't look healthy, and in that case we can salvage the tube if it's unruptured. Okay, like in case of a tubal, like if it's a tubal abortion where there is no damage to the tube, okay, but the tube is distended and there's bleeding from the femoral end, in that case we can do milking, or okay, we can try the conservative method. Okay, but the problem with this is there's a chance of recurrent ectopic. Okay, so the recurrent ectopic, there's a chance of recurrent ectopic, and we need to follow the case with serial serum beta HCG. Okay, so and patient may require the medical treatment even after surgery. Okay, if there is persistent prophylactic activities, like when the serum beta HCG is continuous. Okay, common, so after surgery we have to do surveillance with the serum beta HCG, and if it's detected, okay, weekly if we do, and persistently it is detected and in rising trend, then patient may need methotrexate. Okay, so it's more time consuming, the patient may need more surveillance. Okay, and so it depends upon the patient factor as well. Okay, is he very keen to follow up or not? Okay, so that's why the modality of treatment depends upon the patient as well. And if the patient is subfertile, okay, so patient doesn't have any living issues, and the tube is if the patient is a case of tubal abortion, okay, it's not ruptured ectopic but tubal abortion, in that case we can go with milking, okay, with adequate counseling. Okay, and if we caught it in early, okay, like if it's a unruptured tubal pregnancy, in that case we can go with salpingotomy or salpingostomy. Okay, there are two options. Okay, so salpingotomy means just we give a incision to the anti-mesenteric border, okay, where there is just opposite to the broad ligament anti-mesenteric border, we can give incision, small incision, then we uh, shock out all the product of conception. Okay, remove the product of conception, then we can do the closure. Okay, with very fine suture like 4O or 5O. Okay, so that is a tubal reconstruction surgery. And but if we leave, okay, we do not do suture and leave it to heal with a secondary intention, salpingostomy, that we call salpingostomy. Okay, so in these both cases there may be chance of, okay, persistentoplastic activity if all the chorionic villi are not removed. That's why the follow-up is very, very important. Okay, and this modality of treatment like salpingostomy or salpingotomy or milking, okay, or segmental resection, okay, especially ischemic pregnancy. Okay, so in that case we can do we can remove the defective, okay, if it's a ruptured and only if the defect is very low, okay, sorry, very small, in that case we can resect that part, okay, damaged tube, and we can reconstruct. Okay, so these are the conservative method of surgery, and we usually do this surgery, okay, if the patient is vitally stable, okay, and contralateral tube is damaged, or it's the case of recurrent ectopic and previously our tube was removed, there's no other options available, in that case we can try this. Okay, but most of the cases in our setup, okay, you remember we do radical surgery, that is salpingectomy. Okay, so am I clear with this questions? Okay, another, okay, if this okay, then we can go with another questions. Is immediate surgery is the only management of choice, or do medical management? Okay, so another question is quite straightforward. Immediate surgery is only management of choice, or we can do medical treatment? I think Dr. Samyam has quite well explained this issue, because there are certain criteria for medical management. The patient should be vitally stable, okay, it should be unruptured, case. Okay, the pregnancy, sorry, ectopic should be unruptured. Okay, the size is usually less than 4. Okay, it depends upon the guideline, clinical guideline. According to the NICE UK guideline, okay, it's around 3.5 centimeter. Okay, so the size should be small, serum beta acids should be low. Okay, so preferably less than 5,000. Okay, so it depends upon the serum beta acids as well, size of the ectopic pregnancy. Okay, so preferably less than 3.5 or 4 centimeters. It depends upon the guideline. Okay, patient should be stable, patient should be very keen for follow-up. There is no contraindication for methotrexates. Okay, so these are the criteria, which was well explained by Dr. Samyam. So you can revise those slide. I think that's clear. Okay, so regarding the natural healing, okay, so there is another modality of treatment called expectant management. Okay, so remember, for ectopic pregnancy there are three modalities of treatment. So one is medical, one is expectant management, that is just wait and watch, another is medical management, okay, and another is surgical. Okay, in surgical also there are conservative management or radical. Okay, so expectant means, okay, sometimes uh, there is a cessation of trophoblastic activity on its own. Okay, because tube itself is not a good site for nidation, it is not a good site for implantation. Okay, in fact it is not a site for implantation. That's why not all trophoblastic cells can invade the tube. Okay, so they cannot get implanted. Okay, so because of that they get self-observed. Okay, so how we can know these cases, or how can we know that for which cases we can allow expectant management? Okay, so there are few criteria. So we can do serial beta hcg, and if the serum beta hcg is less than 1000, okay, so serum beta hcg less than 1000, then, and there is serial, so when we repeat in 48 hours there is regression. Okay, so it's in a decreasing trend, patient is vitally stable. Okay, it's unruptured, serum beta hcg is less than 1000. In that case, okay, and the serum beta hcg should be in a decreasing trend. Okay, in that case we can allow for expectant management. Okay, so in that case we can just wait and watch. But if serum beta hcg is a bit high, okay, this sac size around 3.5 to 4 centimeter. Okay, so if it's more than 1000 but usually less than 5000, but in some guideline you can you can get, so less than 10,000 also we can try. But the higher the serum beta hcg level, the chance of success with the medical management is low. That's why preferably if it's less than 5000. Okay, so if all these criteria are met, okay, the patient is fit for if there is no contraindication for methotrexate, so in that case we can go with medical management. Okay, and if not, surgical we just discussed. Okay, so the modality of treatment depends upon the patient, and so what are the serum beta hcg or clinical condition. Okay, the sac size. Okay, so there are different criteria. So I think I made it myself clear about those modality of treatment. So if there is an issue, we can again discuss. Okay. Okay, let's go to another questions. So if there is any confusion, so you can text me or you can interrupt me in between. Okay. So shall we move to another question?
Yes, sir.
Yeah, okay. In severe anemia, we have to give packed cell only or whole blood. Okay, so though we are infusing normal saline too. Okay. Okay, so there is another question. So in severe anemia, because likely he was about to convey with, especially in the relevance of our case, when there is hemoperitoneum. Okay, so it's hypovolemia because of hemoperitoneum. In that case, uh, what is the choice of fluid? Normal saline or whole blood or packed RBCs. Okay, so for to arrange blood it takes time. Okay, so when the patient land up in emergency, so we should know the grouping. So sometimes in most of the patient we may not know the blood group, so we have to do some lab tests to ascertain our blood group. Then we should do a cross matching. Okay, so there is major cross matching and minor cross matching. Okay, at least you need at least half an hour to 45 minutes to do cross matching. Okay, so it takes time for blood to arrange. Okay, so by the mean to buy time for that moment. Okay, so for that time, like around 30 minutes to 1 hour, so we need to maintain the fluid volume to go heart running. Okay, to maintain the circulation. So to maintain circulation, we give normal saline. Okay, so that's why the first choice for resuscitation is always fluid. Okay, that is crystalloid. Okay, and after crystalloid, it's difficult to maintain, then we can go with the colloids. Okay, until the blood available, because we cannot compare fluid with the blood. Okay, so fluid doesn't have the oxygen carrying capacity, but blood, it has the oxygen carrying capacity. That's why it's just to buy time. Okay, so we keep vein open and we run fluid just to buy time to get blood. Okay, that's why for time being we have to resuscitate with the fluid. First choice is crystalloid, like normal saline. Okay, followed by colloids. Okay, like hemacil. Then once the blood is available, right away you have to infuse it. Okay, so now so let's discuss about whole blood or packed cells. Okay, so here this is the case of shock hypovolemia. The whole blood is uh, we are losing blood. Okay, the patient is losing the whole blood, so it's okay to give whole blood. But so but nowadays what the guideline all suggests that what is required for the patient, we infuse that. Okay, so it is the component based therapy. Like if the patient is sort of RBC, here the oxygen carrying capacity is low because of less RBC. That's why packed cells is a preferable choice. Okay, but here the patient is losing whole blood. Okay, so total volume is also lost. That's why it's okay to give whole blood as well. But if the patient is anemic, okay, outside the ectopic pregnancy, if the patient is anemic, hemoglobin just 7 or 6, then if we need to transfuse, then the preferred one is packed cells. Okay, if the patient is having thrombocytopenia, okay, the platelet is just 50,000, then we can transfuse only platelet. Okay, if the patient is uh, PTINR is deranged, coagulation cascade is deranged. Okay, if the patient maybe is in warfarin therapy, if the patient is having a bleeding issue and patient is anemic, in that case we may infuse uh, plasma therapy. Okay, sorry, platelet rich, fresh frozen plasma, FFP. Okay, so it depends. So ideally you should infuse the component therapy. Okay, it depends. But if the patient is losing blood, okay, whole blood, then it's okay to give whole blood if Paxil is not available. Okay, so am I clear with that? So remember the resuscitation fluid of resuscitation choice uh, of fluid during first resuscitation is always crystalloids followed by colloids, and once the blood is available, you have to infuse it. Okay, choice is a component therapy. Like if we need the, if the patient is losing the red blood cells, then packed cells are the choice. But if the patient is losing whole blood, like in postpartum hemorrhage, or in case of, okay, like in the same case, okay, hemoperitoneum, and then whole blood is also okay. Okay, okay, so here's another question. So when to do laparotomy and when to do laparoscopic surgery? Okay, I think Dr. Samyam has also discussed this thing as well. For laparotomy, especially in case of emergency, if the patient is unstable, okay, there is hemoperitoneum, then obviously we have to go for laparotomy. Laparoscopy, it takes time. Okay, so laparoscopy, it takes time, and it is a minimal access surgery. Okay, so it takes time, and if the patient is stable, then only we go with laparoscopy. So patient should be vitally stable. Okay, so if there is, so this case, if the case of early rupture, patient is stable, in that case we can try laparoscopy. But most of the cases with the ruptured ectopic, we always go with the laparotomy. Okay, if it's unruptured and but need to manage by surgically. Okay, so there are certain conditions. If it doesn't meet the criteria for medical management, the serum beta ICG is more than 10,000, okay, or patient uh, is not fit with the certain medication like methotrexate. If it's contraindicated, Okay, in that case we need to go for surgery, and if we need to do some conservative surgery like salpingotomy or salpingostomy, the patient is stable, in that case we can go with the laparoscopic. Okay, but bear in mind that if the patient is in emergency, is in shock, you always have to go with laparotomy. Okay, and the criteria for laparoscopic surgery, I think I need to confirm the serum beta hCG. Okay, so there is uh, it's less than 600. I think I need to check that because there is not such criteria. Okay, regarding the serum beta hCG. So below 5000 we can go with method exit, I mean a medical method. So I need to check that. Okay, so there is not hard and fast criteria with serum beta hCG regarding the laparoscopic surgery. Okay, the tubal size, okay, this if the ectopic mass less than 6 centimeter. Okay, and the patient is stable, if the patient is stable, there is minimal surgical difficulty, okay, minimal adhesion, in that case we can go with laparoscopic surgery. But regarding the serum beta hCG, I need to check. Okay, I think it's, is it 6000, Dr. Samyam? I'm a bit confused. Okay, I will check it. Okay. Okay, what is observed in pervaginal examination if we suspect rupture ectopic? Is it needed? Yes, I think this case is also this question is also answered by Dr. Samyam. Okay, so if you have diagnostic modality right away, okay, if you have ultrasound available, then if you confirm she is pregnant and free fluid while doing ultrasound, okay, if you diagnose, okay, in a view of urine pregnancy test positive, there is free fluid in the peritoneum, and you can see the adnexal mass, and most of the time, okay, then you will diagnose with the ultrasound. Okay, so main aim of examination is to corroborate your findings and um, to make diagnosis. Okay, once you diagnose with ultrasound, then if you do not extract more information from pelvic examination, then you can avoid it. Okay, so but sometimes when there is ultrasound is not available, in that case pulp vaginal examination is very useful. Okay, here we cannot extract much information, okay, like uh, we get in ultrasound. Because of the pain, patient may not allow you, or patient may not be relaxed, so that we cannot appreciate the adnexa well. Okay, but cervical motion tenderness you can appreciate. Okay, so it depends upon the setup. If you are in the periphery, there is no ultrasound available, and there is a high index of suspicion, in that case you can counsel the patient and you can do gentle PV examination. Okay, but in our setup where immediately you can get ultrasound service. Okay, so most of the time, okay, in emergency, so there is ultrasound available in bedside. Okay, so in that case you can skip the vaginal examination. Okay, so it's not mandatory, so it depends upon the case basis. Okay, so in what type of setup you are. Okay, but of course it will give you some information, okay, in the absence of diagnostic modality. Okay, so it depends upon the case and setup as well. Okay, but in case of OPD, the patient is stable in first trimester PV examination. So in that case, you can do a gentle PV examination to look for the uterine size. Okay, so if the uterine size is less than the gestation, and you may appreciate, sometimes you may appreciate adnexal mass. Okay, so in that case you need to send the patient to ultrasound to confirm ectopic. Okay, but ultrasound has made our life very easy. Okay, because of that, in almost all cases we send dating scan. So because of that we skip PV examination. Okay, so it depends upon the setup. Okay, okay, I think these are the questions I saw in the chat box. So any other queries or any confusion, then you can text me or ask me.
Sir, one of the participants has asked to elaborate more on the differential diagnosis.
Okay, very good question. I think we missed that part. Okay, so if the patient with the first present with the first trimester PV bleeding, okay, or pregnancy with bleeding in first trimester, you have to always rule out three things. Okay, so it can be abortion, it can be ectopic pregnancy, it can be molar pregnancy. Okay, so differential diagnosis, so while forming a differential diagnosis, okay, it depends upon the symptom wise. Okay, if the patient chief complaint is pain abdomen, then the differential will be, it can be ectopic pregnancy, we have to rule out ectopic pregnancy. Okay, it's just like if the patient present with chest pain in emergency, then you always rule out myocardial infarction. In the same okay, the same instance, as similar the in same note, if the patient always with pain, pregnant patient in first trimester, if patient present with the pain abdomen, you should always rule out ectopic pregnancy. Okay, so differential diagnosis of patient with the pain abdomen, okay, in first trimester, so one is ectopic, you have to rule out it. Okay, though just 1 to 2% of the cases may have ectopic, but you have to rule it out. Okay, because this is the most sinister. uh, okay, and another is maybe just urinary tract infection. Okay, maybe just constipation or bowel issues. Okay, so any cause, okay, any issue with the pelvic viscera. Okay, an abdominal issue can cause, like even appendicitis can cause pain abdomen. Okay, it can be surgical cause. Okay, non-gynec cause. Okay, so but if the patient pain come with the pain abdomen, so your first differential diagnosis should be in pregnancy with pain abdomen, your first differential diagnosis should be ectopic. Okay, and so until and unless you rule it out, okay, you have to, you should always, I mean, you should always think of ectopic. Okay, until and unless you rule it out, and other are likely benign. Okay, so maybe just a urinary tract infection or constipation, or sometimes it can be surgical abdomen. Okay, so it can be acute appendicitis. Okay, so if you consider the pain as a chief complaint, if you consider, if the patient is also having the issue with PV bleeding, okay, and if you consider the PV bleeding as a differential diagnosis, then sorry, PV bleeding as a chief complaint, then the differential diagnosis will be, there are three differential diagnoses. So one is ectopic, you have to rule out ectopic if the patient is also presented with the PV bleeding in the first trimester. Okay, so first and foremost, you always rule out ectopic pregnancy, because this is the, you should, if you catch the time, if you diagnose it timely, then we can manage timely, and the morbidity as well as mortality could be, okay, reduced. Okay, so that we all discuss today. And another differential is molar pregnancy, which is also very sinister. Okay, so if we timely diagnose, we can admit the patient, and we can arrange for suction evacuation after preparation. Okay, so that is also another differential diagnosis. And another one is abortion. Okay, so it can be threatened abortion, or it can be incomplete, it may be complete, it depends upon the clinical it depends upon the history and clinical examination, as well as it can be ascertained by ultrasound. Okay, and all these three, okay, so molar, ectopic, and abortion, it can be ruled out by ultrasound as well. Okay, so these are the important diagnoses. Okay, and pelvic inflammatory disease is not that common in pregnancy. Okay, so but it can be considered in the differential diagnosis as well. Okay, if the patient has a risk of sexually transmitted infection, okay, multiple sexual partners, history of recurrent past history of PID, pelvic inflammatory disease. Okay, so in that case, it can be okay, it can be considered in a differential diagnosis. Okay, so I think regarding the differential diagnosis, these are the important ones.
Thank you, sir. Now I think there are no more questions. So I would like to thank once again Dr. Santosh and Dr. Samyam for the very fruitful and insightful discussion today. We really got to learn a lot about the topic, and we would like to present a small token of love from our side. So I request Aisha to kindly present it.
Okay, thank you. Thank you so much for providing me this opportunity in this platform to share a few words regarding the ectopic pregnancy. Okay, I would like to thank all the great Medicos team for providing me this opportunity. Okay, thank you very much.
Thank you so much, sir. Now I would like to request Aisha to present the other token of love to Dr. Samyam. And Dr. Samyam, we would like to hear a few words from you as well.
For providing me this opportunity. I hope it was very, very helpful for you all. And you must have understood the art of history taking in case of ectopic pregnancy, how the case is approached in emergency or in wards. So as a whole, I would like to say thank you to all of you and all the best for all of you and for your upcoming exams. Thank you.
Thank you so much. Now I request Subhash Pandey from Kist Medical College to kindly propose the vote of thanks.
Thank you, Achal. Hello, everyone. It's me, Subhash Pandey from Kist Medical College. I'd like to thank our mentor for today's sessions, our respected teacher, Dr. Shantosh Sharma sir, and presenter for today's session, our lovely Dai, Dr. Samyam Bickram Pathak, for such a wonderful presentation on the topic ruptured ectopic pregnancy. It was a wonderful session on this topic, and I personally was unable to attend from the starting of the session, but from when I joined the session, it was so fruitful for me, and I have learned so many things that I couldn't learn during my theory classes and during my practical session in my college as well. So I hope all the other audience present here also were able to catch up lots of things regarding the ectopic pregnancy. Once again, I would like to thank our presenter and mentor for today's session. Thank you very much.
Thank you so much, Subhash. And I once again thank Subhash for coordinating this program on behalf of Kist Medical College. And I would like to congratulate and thank all the working team members of the Grey Medicos for their constant support and for pulling off today's program also successfully. And I would like to thank all the participants for their active participation. And we have uploaded our the sessions of our previous videos in our official YouTube channel. You can go and watch it there in case you've missed any of our sessions. And to tune in to our upcoming sessions and webinars, you can follow our official Facebook page, The Grey Medicos, and you can also join us in our Viber group. And with this, I declare the ending of today's program. Once again, I thank Dr. Shantosh and Dr. Samyam for taking out their time despite their busy schedule. And thank you, everyone.